When BSCN outsourced there, I want to present to you bipolar and related disorders. I'm sure this lecture was presented to you by your lecturer for about 3 to 5 hours. I want you to take an example of an average learning student and also slow learner and fast learner. I want you to test your IQ the way I'm going to present this to you. Don't concentrate on slides, but listen to what I'm saying. I'm going to pick the main important ideas from this slide. Bipolar disorder is a chronic, recurrent illness that is marked by shifts in moods, energy, and ability to function. Once called manic depression. Signs and symptoms range from severe manic, an exaggerated euphoria or irritability, to severe depression. Epidemiology. What do you need to understand? That 25 to 60% will make a suicidal attempt once in lifetime. So those who are in bipolar or related bipolar disorders, 25 and 60% will, at the end of it all, make suicidal attempts. 20% of death from this population or patients result from suicide. So if all those who are bipolar, if they were to die, 20% of their deaths will result from suicide, if not other conditions. Historical background. Just want to define melancholy, which derives from melas, which means black, and chole, which means bile. It's an ancient Greek word. And then Hippocrates, the father of medicine, thought that depression resulted from an excess of black bile. Mania derived from menos, which means spirit, force, passion, to rage, go mad. Depression derives from the Latin deprimere, press down, which means to sink down or press down. A sink, a basin, something with a depression, something like a basin. Then in the historical background, since from 1854, I don't want you to remember all this. I just want you to remember from 1980, where the term bipolar disorder replaced manic depression disorder. I repeat again, 1980, the term bipolar disorder replaced manic depressive disorder, which is found in Diagnostic Statistical Manual of APA, means American Psychiatric Association, DSM-3, which generalizes all psychological disorders. Again, in epidemiology, what do I want you to pick from this slide is that the onset of bipolar 1 is about 18 years and bipolar 2, 20 years. Bipolar 1 is more in men. That is an MCQ. Bipolar 1 is more in men. Onset of bipolar 1 is 18 years. Onset of bipolar 2 is 20 years. That is a difference between the two. What do I want you to pick from here? The bipolar 2 is more in females. A difference, bipolar 1 is more in men or in male. Women with bipolar are likely to abuse drugs, commit suicide, and develop thyroid disease, while men are likely to have legal problems and also commit suicide. Look at the two differences. Women with bipolar are likely to abuse drugs, commit suicide, and develop thyroid disease, while men are likely to have legal problems and also commit suicide. What do I want you to pick from here is that bipolar 2 more confused with depression or personality disorder. Take care of that. That is a question. Bipolar 2 more associated with suicidal attempts. Cyclothymia begins in adolescence or early adult. That is also an MCQ. That cyclothymia begins at adolescence or early adulthood. Cannot start in any different age bracket from those ones. Early adulthood or adolescence. Bipolar 2 with attempts of suicide. Let's go on. 15 to 20% chance that patients with cyclothymia will develop bipolar 1 or bipolar 2. That's our probability. 15 to 50% are the chances that patients with cyclothymia will develop either bipolar 1 or bipolar 2. And remember, we have said these are the people who are either in early adulthood or adolescence who have cyclothymia. Comorbidities. Comorbidities are other conditions that may occur together with bipolar, or one can cause the other, or one can interfere with, can extrapolate the other. Panic attacks 62%, alcohol abuse 39%. We have also gastric ulcers, social phobia 38%, and these are people with bronchitis, hypertension, chemical sensitivity, and migraine. We also have specific phobia, 35%, oppositional defiant disorder, 7%, seasonal affective disorder, 5%, chronic figure syndrome, and asthma. In biological factors, what do I want you to pick from here is that 80 to 90% we have biological factors, and other genetics is that 80 to 90% chances 5 to 10 times are higher for people with relatives who suffer from the same conditions. That is more related with families who have suffered bipolar and related bipolar disorders. We also have twin studies that the concordance rate among monozygotic twins is at 60 to 80%, while among the zygotic twins is between 10 to 20%. So you can see 60 to 80% and 10 to 20%. It's more about genetic. Twins, concordance twins, monozygotic twins share much more than the zygotic twins. Also, what do you have to pick from here is that family studies, risk for children with a sick parent is 28% of both parents are sick, then the rate is 2 to 3 times higher whether raised by same parents or adopted. Genetic involved. Just don't look at that slide. Listen to what I'm saying. There is a genome, ANK3, that encodes enzyme diacylglycerol-kinase. And this diacylglycerol-kinase, if it is expressive in the body causes bipolar. But you have also mood stabilizer agent called lithium, as you have heard from your pharmacology class, that lithium inhibits ANK3, this genome that increases the diacylglycerol. Therefore, what does it mean? That it's also confirming that it's more related to genes. And we also have circadian genes that work the same as NK3 that may cause super fast biological clock resulting in insomnia. So if they are increased, these genes are increased, then you will have bipolar. For example, we have schizophrenia, abnormalities on chromosome 13 and 15 that work of the same. Then we have more studies that show that genome that regulates influx or outflow of calcium have been related to the same action of calcium channel blockers, that calcium channel blockers sometimes used in treatment of bipolar disorders work by reducing or regulating the genome that regulates influx and outflow of calcium. Therefore, if calcium is increased in the cell, we expect hyperactivity, muscle contractility. We also have biochemical influences. I want you to pick two things here. That mania means man-like activities. Man, strength, contractility of muscle. Depression means down, means abasing. And therefore it means if you have mania disorder, you are going to have increased dopamine, increased serotonin, and increased norepinephrine. And opposite, vice versa, is to the depression. If you are going to have depression, you are going to have lower biogenic amines. You are going to have reduced norepinephrine. You are going to have reduced dopamine and serotonin. We also have research showing that an appropriation of neurotransmitters and receptor insensitivity that are associated to bipolar. What does it mean? That if GABA, which is inhibitive in nature, which inhibits in nature, if it is less, then we are going to have stimulating neurotransmitters unproportional to the GABA. For example, if you are going to have norepinephrine, which is increased, and we have less GABA than normal, then that is unproportional of neurotransmitters, and we are going to experience bipolar. Receptor insensitivity, it means GABAergic receptors or dopaminergic receptors, we are going to have them not responding or not binding the GABA or not binding dopamine, then we are going to have bipolar. Because if the GABAergic receptors are not going to bind GABA, then we are going to expect the action of dopamine or serotonin to increase, to be overexpressed. Also, we have interaction between neurotransmitters and hormones. If For example, we are talking of estrogen interaction with neurotransmitters. If they are not going to interact normally, then we are going to have problems with bipolar.